Good evening, everyone. It is a real pleasure to welcome all of you to this evening session, the VCare lecture series organized by the Humane Care Expert Committee of the Sri Lanka College of Internal Medicine. As you know, the VCare series aims to promote a more humane and pragmatic approach to the medical practice, one that blends scientific excellence with compassion and empathy. Our committee, led by Dr. Ganaka Seenaratne, under the guidance of our president, Dr. Nishant Jayasekara, and the college council, is dedicated to that mission, highlighting the humane side of care. Tonight's lecture focuses on a fascinating and deeply meaningful theme, understanding the many phases of empathy. We are honored to have with us a renowned clinician and a beloved teacher, Professor Rifdy Mohideen, Emeritus Professor of Medicine, who embodies the values we are here to discuss. Ladies and gentlemen, before we begin, just a few quick notes. Please ensure your microphones are muted and your videos are turned off during the lecture to avoid interruptions. A QR code will be appeared on your screen shortly. This will take you to our Humane Care WhatsApp group, where we connect professionals who share an interest in this initiative. If you are interested, you all can join with this QR code. Another QR code will be shown at the end of the lecture. It links to a Google form for feedback and CPD certification. Please note that this QR code will remain active only for 2 hours after the session. Those who complete it within the time will receive the certificate with CPD points within 2 weeks. Now, I'd like to warmly invite Dr. Nishant Jayasekara, President of Sri Lanka College of Internal Medicine, to welcome the audience and to introduce our distinguished speaker. Over to you, Nishant.
Thank you very much, Dr. Rohita Gamlat. It's with great pleasure and gratitude that I welcome you all to the third session of our VCare webinar series, an initiative by the Humane Care Expert Committee of Sri Lanka College of Internal Medicine. This committee is one of the 6 expert committees of the college, each dedicated to advancing a critical pillar of patient care. Among them, this committee holds a unique mandate to champion humaneness in clinical practice, ensuring that compassion, empathy, and dignity remain at the very heart of medical care in Sri Lanka. We owe much to the guidance of giant leaders like Professor Saroj Jayasinghe, who has been an unwavering beacon in our journey to bring the values of humane care from principles to practice, from paper to the patient's bedside. While today's webinar is on expression of our mission, the committee's work extends far beyond this to advocacy, training, and integrating humanness into the culture of our wards and reward the champions. So as Dr. Gamlat very correctly said, we are honored to have Professor Rifdy Mohideen, Emeritus Professor, one of our most respected teachers and my personal teachers as and my mentors, as today's distinguished resource person. His talk on understanding the many phases of empathy promises to be insightful and deeply relevant to all us navigating the complexities of clinical encounters. A special thanks should extend to Dr. Ganaka Seenaratne, whose steady leadership continues to inspire this committee's work, and to Dr. Rohita Gamlat to gracefully moderating today's session. So without further ado, may I invite Dr. Gamlat to proceed with the rest of the webinar. Over to you, Rohita.
Thank you very much, Nishant. The VCare lecture series was initiated by the Humane Care Expert Committee with the vision of bringing humaneness to the bedside. May I now invite Dr. Ganaka Seenaratne, head of the committee, to share a few words about this inspiring initiative.
Thank you, Gamlat. May I share a few slides? Can you see them, Gamlat?
Yeah, we can see, Ganaka.
Right. Good evening to all of you, dear Mohideen sir, and all of you who have joined today. I would thank you very much for joining with this third webinar of VCare series. The Expert Committee on Humane Care functions under the vision of bringing humaneness to bedside, as Krishant and Kamla said, which is one of the most important facets of our day-to-day practice. So the expert committee was established in 2022, and we've been doing many programs since then. And this is our enthusiastic committee this year. And this is what we've been doing and we've been planning for year 2025. First, we were able to held a symposium on human care in under the theme of bringing humaneness to bedside. The setting clinical standards in medicine, island-wide doctors and nurses programs program by the college. That is the beginning of the year. We had 3 lectures for both the doctors and nurses under these themes, covering around, I think, 110 hospitals island-wide. And then regional meetings, we went to all the regional meetings in 2025, Jaffna, Badulla and Polonnaruwa, and we were able to do these 2 lectures in each session, making medical care more human for doctors and then effective and humane communication for nurses. And we initiated another special project called Humane Care Initiative, that is to sort of recognize healthcare professional who provides human care in our ward setup. All the SLC members have been invited to nominate their juniors, other healthcare professionals, whom they believe that provide human care and under observation, and through a special Google form. And each one of them, and at the end of the year, if the submissions are selected, then they will be personally appreciated for their excellent care. So that is called Humane Care Initiative. And then we are hoping to have a pre-congress session on SimCon, upcoming SimCon, on a storytelling session named as Heart of Healing, Life Stories of Illness. Believe that this heartier session would bring this facet of medicine into fore. And we are trying our level best these days to make a book on bringing humanness to bedside as well. And coming into webinars, this is the first webinar we did. Professor Roger Singer did the first webinar, The Person Beyond the Illness, a Human Approach to Patient Care. And then the second webinar also done by Prof. Jayasinghe. And we are here for the third webinar, titled Understanding the Many Phases of Empathy. I'm really honored and delighted to have Prof. Mohideen, who's actually the teacher who taught me the first lesson of empathy, I believe, when we were registrars, who usually used to say when we are puzzling about getting patients from other wards and exhort patients, you first accept the patient and do whatever you could, and then negotiate with other wards and other teams. So that's the first lesson I believe I had from him in the field of empathy and compassion. So thank you very much, sir, once again for joining with us. May I hand over the proceedings to Gamlat for the further moderation. Thank you so much. I am so much happy to have this webinar unfolding today. Thank you so much. Gamlat?
Thank you, Kanaka. As you very correctly said, empathy is at the heart of human care. To truly understand and heal our patients, we must appreciate their emotions, fears, and expectations. That is, see them as whole individuals. This evening, we will explore empathy from many different perspectives and discuss how to apply it more effectively in our daily practice. As we all very correctly mentioned before, we are really honored to have with us Professor Rifdy Mohideen, a distinguished clinician, and of course, a role model to generations of Sri Lankan doctors. On a personal note, I feel privileged today to moderate this session, as Professor Mohideen was my examiner for final and long case many years ago. So without further delay, let me welcome Professor Rifdy Mohideen to deliver his lecture. Over to you, sir.
Thank you, Dr. Gamlat, Dr. Krishant, and Dr. Ganak for your kind words and your generous introduction. Let me have this slides, share the slides for, has that gone? Okay, so actually it's been a while. I've done a talk late in the evening, and when I was just waiting for proceedings to begin, I got sort of COVID vibes. We were doing these things on a regular basis during the pandemic. Anyway, thankfully that's in the past. Let me thank initially the Sri Lanka College of Internal Medicine for inviting me to participate under this series of WeCare talks that you have successfully carried out over the preceding months. I'm really impressed by your program that you just displayed and your commitment. I must acknowledge the intervention of your past president, Dr. Ganaka Senaratne, who ambushed me during my usual stroll along the ramparts and arm twisted me to deliver this talk. The empathy born in me responded with compassion to his request, and here I am. So let this be a lesson, actually. Exercise is good, is great for the heart, but it's apparently hazardous to your calendar. Okay, so let me share with you what I'm going to talk this evening. It looks a long list. I will go through the definition of empathy and those related terms, discuss the empathy categories. I'll also bring in another aspect of empathy, that what we might believe empathy might not be true in all cases, so not all empathy would be the same. I'll dwell into the neurobiology of empathy. It's quite a fascinating some advances of empathy. Also introduce some empathy deficit conditions, and thereafter focus mostly on clinical empathy and how to improve empathy, recognize the barriers to foster empathy, and also highlight some the decline of empathy among students and professionals, how to measure empathy, and also discuss if empathy can be taught, and the impact of AI and social media before I conclude the talk. And I hope I get through this before you start snoring or snoozing. Okay, here is a powerful metaphor for empathy. It's often referred to as walking in someone's shoes. And if you look at that shoe that has been displayed, it's got tattered and broken. So, and your shoe is inside that broken shoe. So that's exactly a great metaphor for what empathy is about. Well, let's try to define empathy. It's an emotional, let's get this out. It's an emotional response that arises when one person feels what another person is feeling. And that's basically what empathy is about. It's a deeper emotional connection that involves understanding and sharing in the emotions of another person. So there's a element of understanding and sharing of emotions. There's emotion, there's understanding involved in the meaning of empathy. So, and also it requires the ability to put oneself in another person's shoes and imagine how they might be feeling. So these are some of the features of empathy. And as we discuss in the next few slides, we'll see how much deeper that we can get into the definition. Now, the word empathy first appeared in English in 1908 as a translation of the German word Einfühlung, meaning in feeling or feeling into. So, in fact, not to say that empathy did not exist earlier, they were described in other ways, but this recognition of this term came just over a century ago. M means in Greek, pathos means feeling. So empathy literally means feeling into. Now, one of the things that we need to distinguish from empathy is the word sympathy. Now, this slide just illustrates the difference between the two entities. Where empathy is where we get empathetic is being to understand the emotions of a person, as shown in this cartoon. Sympathy, it's a feeling of pity or sorrow for someone who else is suffering, without necessarily understanding or experiencing that suffering oneself. I'll elaborate that in the next slide. Now here, again, trying to compare sympathy, empathy, and this other aspect of a common term of compassion. So here is a person who has got deep into a hole, and this person is just observing this person. He feels sorry that you are in this hole. So this is an emotional response that arises when one person feels sorry for another person's situation or predicament. However, sympathy can also be a passive emotion that doesn't necessarily lead to action or engagement with the person who is suffering. While empathy, in this situation, the person has joined this person in this deep hole and has engaged, is beginning to engage with this person. So it's a powerful emotion that can help individuals connect with others on a deeper level and build stronger relationship. Feeling a resonance with the patient's emotions, such as fear or grief in this instance. Now, compassion is an emotional response that combines both sympathy and empathy, with the added element of a desire to alleviate suffering. That's a desire to help out. So, compassion is an active emotion that requires individuals to engage with others who are suffering and take steps to alleviate the pain. So it's important to distinguish these terms so that when we communicate or we talk about these entities, we are clear what is what. Now so empathy is considered to be the precursor to compassion. So that empathy comes first, and then only you can be moved into action. Now, there are common categories of empathy, 3 of them, what is called cognitive empathy, emotional empathy or affective empathy, and compassionate empathy. So let's look at each one of those. Now, cognitive means actually understanding. It's an ability to understand the feelings and perspectives objectively. That means from the side of the patient or the person. So, for example, if somebody is anxious about, let's say, undergoing a medical procedure, you must be able to understand that why this person is anxious. You first do understand before you do anything else. So quite often we may be tending to dismiss that. That means we may are not that empathetic to that response by the person when you suggest that a medical procedure needs to be done in this state and the patient is not very keen to do it or is anxious about doing it. So the first thing is to understand, and that's cognitive empathy. Secondly is emotional empathy or effective empathy. It's the ability to experience another's feeling. So you understand and here you feel the emotions. So if somebody is in distress, you should be able to feel that distress if you have been emotionally moved. Then comes compassionate empathy. As we talked about compassion in the previous slide, goes beyond simply understanding and feeling. That means you're moved to help. What can I do to help in this moment? So these are the three types of empathy, common categories of empathy. Now, you might wonder, okay, so there's another category of empathy called the somatic empathy. Somatic empathy is a physical reaction to another person's pain, sorrow, heartbreak, or other emotion. I'll give you an example, and I showed you here this, it's called a second-hand embarrassment as an example. For example, you see let's say a cricketer in one of the important matches goes on to take a simple catch and drops it, right? There's embarrassment to that fielder who actually drops the catch. There is also embarrassment to the spectators, or you as a TV viewer will also feel similarly embarrassed. So what is called a second-hand embarrassment. You will react almost similarly to the fielder who will actually hit his hand over the head, or he will stare or show some disappointment. So you react physically. When you react physically to that kind of observation, we call it somatic empathy. So I gave you a negative one here, but again, when sometimes you see somebody smiling, you do also smile at the same time. So it can be also a positive thing. So it's behavioral and it is overt. Now, cognitive empathy is not overt, as I mentioned in the previous example. You won't notice that you have understood. You don't need to show it. But in somatic empathy, you actually show it up, right? And it can manifest with a physical action. So the theory is that the emotional energy moves between people and attaches to us like a lint or Velcro. So you see, that means when we observe something in people, we tend to react, and we tend to react very similarly. So there is a connection between those two individuals. We will discuss why that occurs, and this trance occurs due to what are called mirror neurons. I'll come back to that in a little detail later on. Now, there are other forms of empathy, and I think quite often we may not recognize. We would have even not understood that earlier. Because empathy is not inherently moral emotion. We get, that one ought to feel, nor does it automatically motivate pro-social behavior. So there are aspects of empathy that's not always like positive, right? Though we often think of empathy as synonymous with kindness, that isn't entirely accurate. Empathy is not the same as compassion, as I've been telling you previously. At its core, empathy is the ability to understand others' perspectives, what they feel, what they think, what they fear, what they want. That understanding can be wielded in service of a greater good, or it can be exploited. So here is that's such example, what is called dark empathy. Means a person is skilled at reading others' emotion, but uses this knowledge to gaslight, manipulate, deceive, and get otherwise what they want of you. There are some very interesting examples without naming names. I think these features are found in some of the world leaders who understands. So what it does is they know what exactly their followers want. They know what they want. They manipulate that, right? They don't understand, because empathy is also about understanding. Cognitive empathy is about understanding, but not willing to be compassionate, not willing to help out. So they exploit that understanding in order to do mischievous things or manipulate and deceive. So that's something that you must recognize, that not all empathy is beneficial. Then there is a thing called chauvinistic empathy. It's common and potentially destructive. Now, empathy is selective here. It's only extended to other members of one own in-group. Now, you may think of so many examples here. That means you extend your empathetic behavior to something that you would like only to benefit, not to others. So you could look at it on a racist point of view. You see, you will actually help out or understand a certain certain group that you're in favor of, but not to the others. So you selective. So this is called a chauvinistic empathy. There's also a thing called tactical empathy, where you actually use it in situations where it may be business or some other issues, where you actually show that you are understanding, right? You show that you will understand and show some feeling, but actually you're not using it to bring compassion to that person. You're using it to benefit yourself. So there is that kind of empathy as well. And then, of course, you can also have this deceptive empathy, right? Where you actually feign that you're empathetic. Again, with the idea of manipulating compassion. So it creates an illusion of empathy. So these are done with ulterior motives in mind. So these are some of the other forms of empathy that you may or may not have encountered before, but it's worth making note of when somebody says he's empathetic or you notice empathetic. They could belong to one of those other categories, and they are maybe not genuinely empathetic in the way that we might want to think. Now, there is some fascinating neuroscience research on empathy. They have not identified one single neural network with empathy, but rather several brain regions have been found to be involved. And here I show you in when you have cognitive empathy, for example, which is highlighted in gray in this diagram. You see the ventromedial frontal cortex, right, been identified. The dorsolateral frontal cortex has been identified, and some aspects of the temporoparietal junction. So these get actually activated when you have what is called cognitive empathy. You understand, and these get like highlighted, or these get activated, these areas of the brain. There are areas in the brain when your feelings are aroused by empathy. They are different, and there are some that are shared. So And these are important because there are diseases and disease states or disease conditions where some particular area of the brain is affected in those diseases. And in those diseases, sometimes it's the cognitive empathy that gets affected. In others, it is the affective empathy that gets affected. So as you see, the neuroscience has shown that empathy engages both emotional and cognitive parts of the brain. Right. So specifically, if you look, there are the areas that are particularly involved in the anterior insular cortex and anterior cingulate cortex, that is ACC here in that, and also the amygdala and so on, which are involved with emotions. Now, there is another aspect, and I was talking to you about the somatic empathy, how that, because that involved physical effects, unlike where in cognitive empathy, you may not have overt physical effects. And these are actually governed by what are called mirror neurons. Again, fascinating stuff here. So they are the nervous cells of our brain responsible for imitating those actions that unconsciously attract our attention. These are group of brain cells that activate both when you do something or when you see someone else do it. And this occurs very immediately. It helps you feel what others are feeling by mirroring their actions or emotions in your brain. Now, these were discovered by Italy, when they were looking at experimenting with monkeys, and in the 1990s. Now, here again, three areas are highlighted, and just to go through in a little bit of detail here, the superior temporal cortex, right, which is the visual processing area for the motion, the posterior parietal cortex, and the Broca's area are interconnected regions in the brain that play specific roles in the functioning of mirror neuron systems in humans. The mirror neuron system in humans begins in a part of the brain known as the superior temporal sulcus, right, which analyzes is now conveyed from the STS to the posterior parietal cortex, where the mirror neurons are initially activated. The connection between the STS and the PPC in this diagram is believed to facilitate our ability to replicate the movement we observe in others. So if that one actually has some movement, we will do the same thing because of this particular activation. So the visual and the motor information integrated in the PPC is then relayed to the frontal cortex, with some of this information also reaching the Broca's area, a region involved with processing language. So you might actually say something as a result of what you may have seen. So this is the circuit of activation that occurs during what is called a somatic empathy process. So let's say an everyday example would be, if you see somebody fall, for example, and hurt themselves, you might notice that your body actually will shudder or tremble a bit, making you feel uneasy. Now, this is exactly what would happen. The system mirrors and empathizes with what you see around you embedded in this neurological system. So the mirror neuron system actually underpins the process, the neurological process of some of these empathetic actions. So, and I mentioned to you that there are empathy deficit conditions. There are conditions where empathy is not seen, and here is a list of those conditions: from autism spectrum disorder, schizophrenia, depression, substance use, and so on and so forth. So they have either reduced or impaired empathy, right? While empathy deficit is not the core symptom or the core feature in these conditions, they are not the core features. The deficit is noticed only in the advanced stages or only when the condition is very severe. In some conditions, only the cognitive part is affected. Example, in schizophrenia. In others, the affective emotions are involved. For example, post-traumatic stress disorders. While in others, it shows both affective and the cognitive aspects. Let's say like in the traumatic brain injury. So here are some examples. It's a predominantly cognitive attributes that involves first an understanding of the patient's pain and suffering, combined with the capacity to communicate this understanding and an intention to help. So you need, in clinical empathy, there are three components: understanding, the behavioral component, communicating, and the intention to help, right? In order to produce a favorable outcome. Now, what are the benefits of clinical empathy? I think it has been shown in many studies that it has tremendous benefits when it comes to patient care. One, it improves patients' trust and understanding, right? The empathetic doctor actually impresses upon the patient that the doctor is trustworthy and also has understood the patient's complaints or whatever, right? So that's an important benefit. It improves patient satisfaction. It leaves the patient satisfied by that encounter with an empathetic consultation. It also has been shown that you are able to diagnose diseases more accurately. And this might stem from the fact that your interaction with the patient might be a little bit more deep, more intensive, and that provides more information for you in order to facilitate this diagnosis. It also helps to adhere to treatment recommendations. So if you are again empathetic in your approach, you might be able to get the person to adhere to treatment recommendations, and also better clinical outcomes from a number of viewpoints. The clinical outcome has been shown to be including things like better diabetic control or better blood pressure control in patients, right? Through these empathetic encounters. It augments doctors' performances as well. It reduces medical errors and malpractice claims, and that has been well recognized. It also helps you to reduce practitioner burnout and also makes overall higher physician retention. So these are some of the benefits of clinical empathy practice properly. Now, how do you practice clinical empathy, right? So there are ways in which you might be able to facilitate this. For example, you need to take the patient seriously. That means you have to explore, actively seek information about and actively listen to the patient's perspective. You become more curious and explore the patient's wider social, cultural, religious, moral, and familial background maybe. And in that process, you shouldn't be judgmental, right? You have to take this very neutrally and explore. And this is something that may not be happening enough. Then treat them as an individual, not like numbers or cases. right? So it involves patient and the doctor together reaching a shared understanding of the patient's circumstances, values, preferences, and options, right? Then you to listen attentively. And that is one aspect that needs to be emphasized in order to practice this clinical empathy. Then you have to generate some kind of closeness with the patient and have a holistic view on patients. So at the end of this process, what happens is you can actually plan out a therapeutic course of action in this patient, a management plan, while discussing this patient, the options with the patient, whom you now have actually become a little more closer by this approach. Now, what are the barriers to foster clinical empathy? There are several, and predominant of that is maybe physicians' time pressure. No doubt we are all very busy. There are pressures from the workplace, right, within the time span, and also organizational issues. So this will prevent doctors from fully listening to patients. What I just mentioned to you on a previous slide you may not be able to fulfill during each one of those consultations. And due to those organizational workplace pressures, you might not be able to provide sufficient time in order to probe and engage with the patient. Then one of the other things that might can happen is failure of to acknowledge patients' emotional needs as integral to both illness and care. We only look at their physical ailments, and we may actually shy away from exploring if there are other issues that affect this patient. Again, these are not probed enough. As a result, you do not recognize or you do not unearth these aspects that need attention. Then, of course, increased rates of burnout in physicians due to excessive workload and emotional distress among healthcare workers also contribute to as a barrier. Then many of us might lack the training and education and empathy skills. It may have been done on one occasion, but it is probably not got reinforced on subsequent times. As a result, those skills have got waned off and they are not emphasized. There's an institutional culture that does not promote empathetic care. Clearly, that may be because, let's say, if you're going to see in a clinic 100 patients, clearly the organization is not interested in providing that care. They are interested in clearing the crowd, as it were. So your work times and work schedules do not really allow you to engage in these kinds of beneficial methods of dealing with patients. And of course, there are patient issues. Language can be a barrier. So are cultural issues. Disabilities like poor hearing or even lack of health literacy might be also a barrier. So there are a number of barriers that will not allow you to perform as well as you would like. Now, this has been noticed in medical school, among medical students. It has been well recognized that medical students, when they start off, their empathetic scores are very high. They get motivated to be empathetic. They're enthusiastic. And before long, as they move into year 3, when they start doing clinical work, they are inundated by other aspects of the curriculum, right? Exams, and they have been, as a result, their focus on that type of behavior is diminished. And in addition, there are other aspects that get into the to the student. For example, they can get distance, they can get burnt out, they have poor mental health, they can get desensitized, and cynicism also can creep in. And as a result, with time, they are less empathetic. And this has been recognized in many medical schools and many countries, actually, that this waning. And this is not only seen in medical students, this is also shown in professionals who start off well, but with time, actually, they there's attrition of those attributes. As a result, they become less empathetic. So what it requires is you need to have training, sustained training, or you may have intermittent training in order to boost up these skills at regular intervals. And this particular, like these programs that you have just had, is a case in point for where organizations actually can step in when other when other professional bodies might be, or other hospitals or other organizations fail to actually provide for that. Now, can clinical empathy be measured? Yes. And the best known scale actually is the Jefferson scale of empathy. It's a well-known, valid, reliable instrument. It's the most widely used instrument in medical educational research, right? So it's translated into 59 languages and used in many countries. And it can measure clinical empathy in all health professions, students and practitioners. It has a 20-item instrument. There are 3 versions that are available, one for medical students, one for healthcare professionals, and for others for healthcare professionals who are except medical students. So they are all very similar, but there are certain wordings are actually different in the 3 versions. And here is an example of the 20-item Jefferson scale of empathy, which is, as I said, most widely recognized. And using this scale, they have shown a large number of studies to identify what I mentioned earlier about clinical outcomes, satisfaction scores, improvement in control of chronic diseases, and so on and so forth. So these are ways in which you can measure empathy. Now, could empathy be taught? Yes, empathy is a competence that can be taught. Though we are all as humans, we are hardwired for empathy. And except for very few instances, what they say is about 98% of human beings are hardwired. In a few instances, due to genetic reasons or other very serious disease states, we don't have much empathy. But otherwise, humans are well known to have, even animals as well, they have been shown in experiments, right? So it can be not only taught, it can also be enhanced. So what are the conventional ways how you learn empathy? By directly interacting with patients and listening to and sharing their experience. So clinical practice is the one way. Role-playing, standardized patients is one way. Exposure to positive role models. This is where we really yearn for. That means in your clinic, in the wards that we practice, in the clinics that we practice, and elsewhere. And also I notice even among, when we teach students, we forget to be empathetic. We are harsh on students making small errors. We are harsh on trainees. We are not empathetic. We are unforgiving sometimes for small blemishes. And I think it is time for us to reflect on our actions and see whether we could actually reverse the course. Because if you do as a role model, and I think that makes a huge difference. So I spent 9 years, actually, 10 years in Malaysia, and where this empathy training was actually hugely emphasized. But again, I noticed I made a deliberate attempt with students to actually practice that empathy during classroom sessions, taking everyday examples when students do not produce their reports on time, maybe they turn up 10 minutes late to our lecture. How do you react? Or they have failed in some sort of assignment or something during a bedside teaching session. I think we are very quick to jump at them. But if you really understand why that led to those actions or those students, I think it brings. So what I did was I highlight the deficit in that in among the students and say why I acted differently from what they expected. And I think that's another thing that you can actually do. So positive role models are extremely important because that's the most powerful one, I guess, for trainees, right? There are other supplementary ones like studying the literature and arts. They provide great examples, right? Exposure to humanities. They're all theoretical stuff, right? They are reflective writing, narrative skills, all theoretical stuff. They all will tell you, but empathy is about action, right? So it must translate into action, and that's where it's not happening enough. When we have no time and so on and so forth, or when we want, there are other ways in which empathic training can be provided. Some which are cost effective, reproducible. So for example, we can use virtual reality, right? Because you may want to have this repetitive, right? And sometimes because of lack of clinical materials, you might have to develop programs of that, right? Video clips, you can show films that evoke empathy or lack of it, those things, and you can get a comment and ask students and doctors to reflect on viewing these clips, right? And so on. And there are other technological improvements that are being available that can actually enhance empathy training. Now, always you'll have to ask this question these days, can AI replace humans in providing empathy? But the reason is because face-to-face sessions are at a premium, of getting empathy enhanced, right? So there are some pros of using artificial intelligence because AI, among many other things, it's also been used for teaching empathy, right? Because it's low cost with therapy chatbots. But also because it can listen without fatigue, right? Won't get tired, responds without ego, and delivers a presence that can feel uncannily superior. So it might actually perform better than your trainee, right? And they're very more consistent actually. So, and you can engage with an infinite number of individuals simultaneously without exhaustion. So here is another way when you find empathy can't be, you have it in a curriculum, you can't provide for sufficiently and with large numbers involved, right? And you want to standardize your training. Here is one way to go. And it doesn't allow, AI does not allow its emotions to cloud its response. So these are some of the advantages of having AI, right? It's highly consistent and infinitely scalable. But AI can mimic empathy, but it can't care. It can show the empathy, but it can't care. So that's where that human element is missing in empathy, right? And studies have shown that human attributed responses were rated more empathetic and supportive than AI attributed ones. But AI will catch up very soon, right? There are reports that it can actually do better in the course of time. So, so at the moment, AI companions aren't a replacement for meaningful connections, but there is potential that it might be supplementary in some situations, right? What about social media? Impact of social media on empathy and compassion. Now, the pros in social media is that you can connect with global communities. You can engage with people whom you actually don't know, and that's happening. So, and also those who really need, there are marginalized communities and voices that you can engage in. So that's also could be, you can actually show empathy, practice empathy, or get influence and actually practice empathy with those kinds of people out there, right? You don't know them, but you can connect with them, right? So, and also you can explain empathy by introducing global perspective. And these are all seen, you know, in this day and age, the war in Gaza and so on and so forth, how people are moved by suffering, distress, and so on. You don't need to be there. You can actually get moved by things that are happening outside, and you can actually be compassionate. You can react to that. So it's possible. That's what social media might actually provide for. So for people whom you actually don't know much, they are basically strangers. But what happens with social media is more time you spend alone, you have less time connecting face to face. So it's not with your own community that you might do. You actually you disconnect people from your own local community, but you have more connections with somebody outside, right? And also it can expose users to polarizing content. So that can be a little toxic. So that may not be helpful to the user. And also because the amount of endless streaming of information, it can contribute to fatigue and by overloading the users. So that's it actually in this talk. So in conclusion, actually empathy, its distinction from sympathy and compassion, we've already gone through. And I have discussed many facets of empathy, cognitive, emotional, compassionate, somatic, and also those other forms of empathy from dark, chauvinistic, tactical, and so on. So there are other forms of empathy out there, right? It's a skill that can be cultivated. We've shown that it can be taught, right? It can be enhanced and improved with profound impacts on patient care and physician well-being. Clinical empathy is a potent medicine without any adverse effects. No adverse effects for clinical empathy, so you can practice ad lib. Empathy is healing both for those who receive it and for those who give it. And I'll leave you with these words from Maya Angelou. She's an American poet and a civil activist, won many awards. She died recently. I think we all have an empathy. We may not have enough courage to display it. Thank you very much for your patient listening.
Thank you very much, sir, for that enlightening and inspiring talk. As we expected, this has been a truly thought-provoking and enriching session, reminding us of the different sides of empathy and its importance to understand the human values of medicine and, of course, the benefits of empathy. We also learned the possible future effects of AI and social media on a complex human value like empathy. The excellent turnout of more than 130 participants today reflects how relevant and vital this topic is for all of us. Ladies and gentlemen, now I would like to open the floor for a few questions from our virtual audience. You may type your questions in the chat box or raise your hand. We'll then unmute your microphone so you can speak. Please remember to introduce yourself briefly before asking a question. Sir, Dr. Ganaki is asking question. Is the Jefferson empathy scale is validated to Sri Lanka?
I'm not sure really. Worth finding that out. Yeah, very, very valid question actually. I'm sure somebody may have used it who may have either got it translated or, and validated. But that's an important question. I think worth checking it out. I'm not aware really.
So why I asked that question was now we are trying to build up some research among practitioners.
Yeah.
So whether we could use that questionnaire on that particular aspect here.
Yeah, I think worth going through that. Gets just might have to check the literature to see whether it has got validated. I have a gut feeling it may have been, because there's so much of countries that have been using that, so they may have validated, because we do quite amount of that kind of research also, isn't it? So we're checking on that. Yeah. If I find that out, I will. Yeah.
Thank you, sir.
There's a hand that is raised from. Yes, Dr. Rify, I think, has a question. Can she ask that? Yes, please.
Yes, thank you very much. It was an absolutely amazing lecture. And I didn't even know that you people you deal with the topics like this. I'm a retired eye surgeon. Old teachers, our teachers at that time, the first thing they taught us was, it was not called various names, but just bedside manners. And they were exemplary characters who we emulated, because they had such wonderful empathy with people. And I do find dealing with a lot of youngsters, the new doctors and so on, many of the people that I have dealt with totally lacking it. Don't you think, sir, that this should be really a part and parcel of the curriculum as a separate subject even?
Absolutely. Yeah, I think most medical schools have, one of their statements, or many, they talk about providing empathetic care. The question is, as I mentioned, they may be taught in a theoretical fashion, but what might be lacking is, when they get on to dealing with patients in the wards and in clinical situations, how much what they see is translated. So this is where the lasting impression from those learners, you see, they may not see that theory that they learned in practice. So you can't legislate for that. This is the problem. It must come out of the hearts of the practitioners. They must feel it, must be, they must demonstrate that willfully if they want their learners to adopt it. So that's where the issue is. But I'm sure medical schools do provide some form of learning, whether that is sufficient, whether these are validated, whether they are related to actual outcome of their performance, is left to be seen. But as I mentioned, in most medical schools, again, it has been shown that what they learn it at a very early stage in their course, but that learning actually evaporates very soon when they reach time to graduate. So this is what. So we have methods to reverse it. We can enhance these things. So I am hopeful with organizations like the Sri Lanka College of internal medicine at the forefront, at least among the professionals. We're going to raise the profile of these types of humane care, and hopefully we'll see a reversal of those trends. But I quite agree with you that it needs to be reinforced. Yeah.
Yes, when we were HOs, interns, we were specifically taught this. I remember the first thing that my boss taught me, Dr. Sivam Subramanian, was now you have come from home, that is none of your problems are not patient's problem. Now remember, patient has problems, and therefore, first and foremost, put a smiling face and then deal with them as a human being. And I still remember that. So it was taught specifically by many of our teachers. Thank you very much for the lecture.
Yeah, glad to hear that. Yeah.
Dr. Santosh has mentioned that Dr. Amar Suri is one of the senior lecturers in Department of Medical Humanities, Colombo, has adapted Jefferson's care to Sri Lanka, sir.
Yeah, okay. Yeah,
Okay. And there's
I would
another
have thought, yeah.
Yeah, there's another question, sir. Do you think usage of electronics and AI among medical students has caused lack of empathy among, junior doctors?
Well, I think you need to do a proper study to see the effect of these things. But I feel that you can't blame those two technological improvements really for the lack of empathy. If there was a lack of empathy, I think we need to do proper studies to see whether what I just mentioned, what I just told about medical students really is the case in Sri Lanka. I'm not aware whether there have been sufficient studies to quantify whether one thing is teaching enough, whether there is an impact on that. Your question about whether AI, you mean, I have a feeling it may not be the reasons. If there was a lack, I think there may be other reasons, like what mentioned, because the heavy curriculum, exams, and so on, they may be impacting. You see, they are not allowing, and also the culture. You know, if your own institutions and others are not bothered about, or your own teachers are not very keen about empathetic care, and due to the reasons that I mentioned, they may never see that in practice. You see, so I think there is a need at every instance, or at least demonstrate in a particular case. You see how you can be different. Knowing that there are time constraints and so on, can take some good examples in your ward itself and show how you can actually practice empathetic care. Now, I give a frequent example. For example, somebody come with a heart failure. You recognize heart failure. The patient says, I'm short of breath on exertion. So I used to ask the students, how can you be empathetic, compassionately empathetic to that patient? So a lot of students would tell me that they will treat this patient efficiently, treat it in a way that the heart failure improves. Fine, that's actually what you might do. But if you dwell into that history, the patient said, I can't walk 25 yards, I feel short of breath. You're the house officer who has admitted this patient. So I'm just to give you an example. What I would want them is, find a bed that is closer to the toilet, just for example, because he's going to find it difficult to walk. It's not easy, but you try to do that. He's going to be given diuretics for which he'll have to pee many times. So if you put him in a distant place, knowing that he got heart failure and he's got this shortness of breath, that's an example of empathetic care. That is because you took a detailed history about it. You saw his problem, you recognized, you felt that he's short of breath. You had a feeling that he can't walk. What did you do? You did nothing in that case, or you can do something about it. So you make a deliberate attempt to find a bed closer to the toilet. So you see, that is because you are compassionate enough to recognize and you have provided a solution. I'm just giving you one example. Or somebody got diabetes and can't afford the care, maybe. Expensive drugs have to be. So you will avoid those kinds of, that's a very frequent thing. If the patient appears to be, by your probing questions, find that this patient can't afford those frequent visits and so on, you may want to provide medicines, but in a more affordable way, not to allow an outside prescription to be. I'm just saying these are simple examples of that is because you recognize, you understand that this patient has got a problem, you feel for the patient, and then you act on it. So I think the reason why it's not been done, we don't ask. So I would suggest that it's in the history that you start the whole thing. Our histories are not detailed enough to find these things out, what the problems are. You see, for the reason that we have, we are rushed. That's the reason. So we don't ask enough questions to find out what the problems are, and we certainly don't find solutions as a result. So it starts there. I think it starts with the history, a very good history or a detailed one at that. Then only you can identify the problems, right? If you really are serious about addressing these issues.
There's another question, sir. Empathy is essential in palliative medicine practice. Is it risk contribute to burnout in palliative medicine practice, leading respite care?
I think so. I think there is a connection between, people who work in those kinds of things. Doctors, the burnout rates are a little higher. The only thing that which I didn't mention is now when you're dealing with these patients, you must not give overabundance of empathy. You must not get soaked in that too much of empathy, because that will hurt you. You see, and that emotional overload on you might be detrimental. So you need to scale back a bit, you see, of in that empathy. You give sufficient empathy, because time in day out, particularly in an oncology unit or in a palliative care setup, day in day out, you see the same sort of so-called distress or sufferings and so on. I think it can have a telling effect on the practitioner. So they need to guard against that. So everything has a limit. I think So if you zealously practice that, you can hurt yourself. You can hurt yourself. Yeah.
So I think less questions today because you explained most of the things about empathy in detail. Ladies and gentlemen, before wind up, I have one more announcement. The Humane Care Expert Committee has organized our next storytelling session titled Heart of Healing at 7 p.m. on 8th November at the Water Stage, Colombo. The seats are limited, so please make sure to reserve your place early. Well, ladies and gentlemen, our speaker this evening was Professor Rifdy Mohideen, Emeritus Professor of Medicine. On behalf of the Humane Care Expert Committee, the President, and the Council of the Sri Lanka College of Internal Medicine, I wish to express our heartfelt gratitude to Professor Mohideen, not only for revealing the many phases of empathy, but for reminding us how to bring empathy into everyday clinical practice. I also want to sincerely thank to all of you, our council members, consultants, trainees, medical officers, and students, for your time, enthusiasm, and engagement. I would like to express my gratitude to Sir, our sponsors as well. We look forward to seeing you again at the next session of VCAL lecture series. Good night, everyone. And thank you once again.
Thank you very much.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Has
Thank
been
you,
a
sir.
marvelous talk. Learned a lot, sir. Thank you so much for
Okay,
delivering
thank you.
this
Thank you
talk
for
to us.
inviting. Thank you. I enjoyed it too. I learned a lot as well in the process.
Thank you, sir.
Thank you.